Episode 16, Balancing the Workout, Navigating Blood Sugar and Exercise in Type 1 Diabetes. Welcome to Sports Medicine Case Studies. I review published case studies in sports medicine for learners of all levels. Today, I want to discuss three hypothetical cases that were presented by authors Zarahaeva and Riddell in their 2015 article on preventing exercise-associated hypoglycemia in type 1 diabetics. These hypothetical cases illustrate common challenges active people with type 1 diabetes face and practical strategies to overcome them. Case 1. Our first patient is a 26-year-old woman weighing 125 pounds. She has a 12-year history of type 1 diabetes. She's on multiple daily injections, insulin glargine at bedtime and insulin aspart, brand name Novolog, at meals. Her problem, she sustains repeated hypoglycemia during her 80-minute afternoon workout of cycling and elliptical training, despite exercising 4 hours after her last meal. In this case, the core issue identified by the authors is relative hyperinsulinemia. Her body cannot naturally reduce her insulin levels when exercise begins, unlike someone without diabetes. The authors proposed three management options. Number one, adding extra carbohydrates. Consuming fast-acting carbohydrates before and during exercise, up to 60 grams per hour based on her body weight and exercise intensity. Option number two, adjust her basal insulin. Reduce her bedtime glargine by 20% on days that she will exercise, or split the long-acting insulin into morning and evening doses, reducing the morning dose on the days that she exercises. Option three, if other strategies fail, transitioning to an insulin pump with continuous glucose monitoring would provide greater flexibility for real-time adjustments. Case number two, presented by the authors. 17-year-old male athlete, 6 foot 2 inches, 180 pounds, lean with 6 years of type 1 diabetes. He's been on an insulin pump for 3 years and does high-intensity interval training with sprinting. He removes his pump during training, leading to rebound hyperglycemia immediately after exercise. But then he experiences nocturnal hypoglycemia with his glucose ranging from 50 to 70 milligrams per deciliter in the early morning hours. So there were two problems identified by the authors. First, prolonged pump disconnection can cause hypoinsulinemia by the end of exercise and heightened insulin sensitivity in recovery, lasting up to 12 hours. This predisposes individuals to overnight lows. Three solutions were offered by the authors. Number one, conservative correction and bedtime snack. Use only a 50% correction dose for post-exercise hyperglycemia. Aggressive corrections near bedtime have been linked to severe hypoglycemia and even death. Add a bedtime snack with protein and complex carbohydrates. The authors gave some examples of dairy-based smoothies or yogurt with fruit, providing about 7 to 10 grams of protein and 30 to 40 grams of carbohydrates. Option two, program a new basal insulin pattern. Reduce basal insulin by 20% from bedtime through 3 a.m. on days that exercise was elected. This strategy has been shown to largely prevent nocturnal hypoglycemia after afternoon exercise. Option three, stay connected during exercise. Rather than removing the insulin pump entirely, maintain the insulin pump with a 50 to 80% reduction in basal insulin starting 1 hour prior to exercise. This maintains some degree of insulin to prevent post-exercise hyperglycemia while still protecting against hypoglycemia during and after the workout. Case 3. 46-year-old lean active man who combines aerobic and resistance training 4 to 5 days per week, typically 30 to 45 minutes of running or cycling, followed by 20 to 30 minutes of weightlifting. He's been on an insulin pump for 12 years and recently added a continuous glucose monitor. Despite basal rate reductions at exercise onset, he still develops hypoglycemia within 30 to 40 minutes of starting his aerobic workout, leaving him feeling weak for his strength training. The problem identified by the authors is performing aerobic exercise before resistance training causes rapid hypoglycemia, depleting his energy for subsequent weightlifting. There were two solutions offered by the authors. Number one, understand the limitations of continuous glucose monitors and respond appropriately. While glucose monitors are helpful, there is a lag time of 5 to 28 minutes between interstitial and blood glucose readings during rapid changes of blood sugar. Patients should use trend arrows to guide carbohydrate intake. For example, if the glucose is 90 to 110 with a downward arrow, one could consume 16 grams of fast-acting carbohydrates. Also, basal rate reduction should begin 60 to 90 minutes before exercise, not at exercise onset. By changing the exercise order, by doing resistance training first, that could also help. Research shows that performing resistance exercise before aerobic exercise significantly reduces hypoglycemia risk in type 1 diabetes. This approach also decreases reliance on fast-acting carbohydrates during the workout. So some key takeaways that I want to describe, which can be individualized for patients. Okay. Carbohydrate supplementation can be implemented based on pre-exercise glucose and continuous glucose monitoring trends. Number two, insulin adjustments, both basal and bolus, timed appropriately before exercise can be very valuable. Third, exercise type and order do matter, so doing resistance training before aerobic exercise. Fourth, obviously frequent glucose monitoring is going to be helpful in individualizing treatment strategies. And finally, be aware of nocturnal hypoglycemia risk, which extends up to 12 to 15 hours after exercise. Fear of hypoglycemia remains a major barrier to physical activity with people who suffer from type 1 diabetes, but implementing evidence-based strategies can help reduce that fear and enhance overall well-being. I want to recognize the authors. This is a really nice study, and it's free. You can download it, and I'll post it in the show notes. But they give multiple tables to help physicians assist their patients in management of blood sugar with exercise. And so their study, again, it was published in Diabetes Spectrum in 2015, and I think they did a great job. I'm Scott Hall, a primary care sports medicine physician, and I'm studying for my sports medicine recertification exam in 2026. I hope you join me on the journey. This podcast is for educational purposes only. I'm going to next go into some practice questions. Question 1. Medication classes and hypoglycemia risk. Which of the following diabetes medication classes increase the risk of exercise-induced hypoglycemia? Choices. A. Metformin. B. SGLT2 inhibitors when used alone. C. Sulfonylureas. D. DPP4 inhibitors. E. Thiolidazine-diones. So the correct answer is C. Here's the rationale. Insulin and insulin secretagogues, including sulfonylureas, are primary medication classes that increase the risk of exercise-induced hypoglycemia. Metformin, thiolidazine-diones, DPP4 inhibitors, and SGLT2 inhibitors, when used alone, do not require dose adjustments for exercise and carry minimal hypoglycemia risk. However, when SGLT2 inhibitors or GLP-1 agonists are used in combination with insulin or sulfonylureas, the dose of the latter medications may need to be reduced. Question 2. A 22-year-old collegiate soccer player with type 1 diabetes on an insulin pump is preparing for a 90-minute practice session. According to current ADA guidelines, what is the recommended target range for blood glucose prior to exercise? A. 70 to 100, B. 90 to 250, C. 150 to 300, D. 250 to 350, and E. Any glucose level is acceptable if the patient feels well. Answer. B. According to the American Diabetes Association, the target range for blood glucose prior to exercise should ideally be between 90 and 250 milligrams per deciliter. If pre-exercise glucose is 90, carbohydrate ingestion is recommended before starting the activity. If glucose is greater than 350, ketones should be checked and intense exercise should be postponed until glucose levels decrease. Third question. A 26-year-old woman with type 1 diabetes on multiple daily injections plans to cycle for 60 minutes at moderate intensity starting 2 hours after her lunch and bolus insulin dose. Approximately how much carbohydrate per hour may be needed to prevent hypoglycemia? A. No carbohydrate is needed. B. 10 to 15 grams. C. 30 to 60 grams. D. 80 to 100 grams. E. 120 to 150 grams. Correct answer. C. For activities performed with relative hyperinsulinemia after bolus insulin, 30 to 60 grams of carbohydrate per hour of exercise may be needed. This is similar to carbohydrate requirements to optimize performance in athletes without diabetes. In contrast, for low to moderate intensity aerobic activities lasting 30 to 60 minutes, undertaken when circulating insulin levels are low, only 10 to 15 grams of carbohydrates may be needed to prevent hypoglycemia. Question 4. A 17-year-old high school athlete with type 1 diabetes on an insulin pump experiences recurrent nocturnal hypoglycemia, defined as a blood glucose between 50 and 70 at 2 to 3 a.m. following afternoon high-intensity interval training. Which of the following strategies is most appropriate to reduce his risk of nocturnal hypoglycemia? A. Increase his bedtime basal insulin rate by 20%. B. Administer a full correction bolus for any post-exercise hyperglycemia. C. Reduce basal insulin rate by 20% after afternoon exercise. D. Avoid all carbohydrate intake after exercise. E. Switch from the insulin pump to multiple daily injections. Correct answer. C. For insulin pump users, basal rate reductions of approximately 20% at bedtime for 6 hours after afternoon exercise may limit nocturnal hypoglycemia. Exercise-induced nocturnal hypoglycemia typically occurs within 6 to 15 hours post-exercise, although this risk can extend up to 48 hours. Aggressive post-exercise insulin corrections should be avoided as they have been linked to severe hypoglycemia and even death. A bedtime snack containing protein and complex carbohydrates may also be beneficial. Question 5. A 46-year-old man with type 1 diabetes performs combined aerobic and resistance training. He consistently develops hypoglycemia within 30 to 40 minutes of starting his aerobic workout, which is running. This impairs his subsequent weightlifting session. Based on current evidence, which modification would best prevent hypoglycemia during his workout? A. Perform aerobic exercise first, then resistance training. B. Perform resistance training before aerobic exercise. C. Eliminate resistance training entirely. D. Double his pre-exercise carbohydrate intake. E. Skip his basal insulin entirely on days that he exercises. Correct answer is B. Research demonstrates that performing resistance exercise before aerobic exercise reduces the likelihood of developing hypoglycemia in individuals with type 1 diabetes. This approach also decreases reliance on fast-acting carbohydrates during exercise. The mechanism relates to different glycemic responses to anaerobic versus aerobic exercise. Resistance training and high-intensity exercise tend to raise or stabilize glucose levels, while moderate aerobic exercise typically causes glucose to decline. Final question. A patient with type 1 diabetes on multiple daily injections plans to perform 60 minutes of moderate intensity cycling 2 hours after lunch. According to published guidelines, what percentage reduction in pre-meal bolus insulin dose would be appropriate to help prevent exercise-induced hypoglycemia? A. No reduction needed. B. 25% reduction, C, 50 to 75% reduction, D, 100% reduction, in other words, skip the dose entirely, E, increase the dose by 25%. Correct answer is C. For exercise performed within 2 to 3 hours after bolus insulin via a pump, 25 to 75% reductions in insulin may limit hypoglycemia. For 60 minutes of moderate intensity exercise, with examples included brisk walking, jogging, and light cycling, a 75% bolus dose reduction is recommended. For 30 minutes of moderate exercise, a 50% reduction is appropriate. These adjustments should be individualized based on patient experience and frequent glucose monitoring. Thank you.